Okay, good afternoon, good morning, everyone. We're going to start on the making of the Medi-Cal Doula Benefit. I thank you, AV, for throwing it up on the screen for us. Perfect. And I'm just going to test that it works and it moves forward. Perfect. All right, well, my name is Saida Pepper Wilson. I am the executive director and founder of Diversity Uplifts. I'm also a psychologist and a doula. This is, I'll just go in the order that I see it. We have Kefri Riley from Frontline Doulas. We have Mama Linda Jones from Black Women Birthing Justice. We have Mama Samsara Morgan from Oakland Better Birth Foundation. We have Chantel Reynolds from the Sean Collective and St. Hope for Birth Workers Collective. We have Renee Mullo, a former deputy director of DHCS. And we have Kairos Joy from Children of the Sun BP Doula Project. Kairos. And then we'll also have via video Dietrich Epps from Race for Equity. So we are your panelists. I want to say just something, let me go back, about us is that we've been together, working together since 2001 in some capacity for this project. Some of us have known each other for many years before then. And we've definitely become a bit of a family. And so we're going to tell you about our long journey with our different systems and how we got to where we are. Okay, so a little bit about the landscape of California. And we wanted to make sure that folks had this in their minds because these were the things we had to think about in building out the benefit of Medi-Cal for doulas. So people are living all over. People think of a lot of the urban cities in California as like who would be getting a doula, but you have to think about, we have a lot of rural areas. You know, if you take a trip from here to Los Angeles, you're gonna be driving by a bunch of farms and a bunch of land and a bunch of space, right, before you get to the next place. And people live there. Women live there, people are birthing there. Sometimes they have hospitals there, sometimes they don't. They take that same route that you're taking to the next city to get to the hospital. So we knew that there are, medical deserts for people who are birthing, and it's something that we were thinking about as far as having doula support and what does that mean in places that maybe never had doulas ever before this benefit came, and also how people would be served. We also are aware that there have been a lot of hospital closures. Somebody had talked about it earlier yesterday. One of the things that always comes up, like why would people close hospitals for people who are birthing? Even if 5 people are birthing in your area, you want them to be by themselves, right? So it feels like it doesn't make sense, but the reasons that are being given is that there are labor shortages, so not enough providers to provide care in certain areas. If you live, for instance, I live in the Inland Empire, we have a number of people birthing in Barstow. Maybe no doctors want to move to Barstow to have a clinic in Barstow. And so then people don't have a clinic there. They don't have a person to attend births. Increased costs for maternal care, lower reimbursement rates, especially since, as it was discussed earlier, Medi-Cal covers a lot of the births in California, and also declining birth rates. So less people are having babies every year in almost every county in California and throughout the US. And so that means that they're losing money because less people are having babies. And as a result, people are closing hospitals. Another thing we wanted to give context for is that how many people are giving birth in California. So we have almost 400,000 or about 400,000 people that give birth across California. 40% of those are covered by Medi-Cal, so it's 160,000 people giving birth. So then the question is, like, how many doulas will we need to be able to support the number of people giving birth in California? And of course, that's gonna look different in the different regions where people are birthing. And also, we put this slide for the race and ethnicity of people who are birthing, or potentially the people who have access to Medi-Cal, so that you could think of also race and ethnicity, cultural congruence, cultural consideration would be something we'd be thinking about for the doulas, right? We have, more than almost half Hispanic and Latinx community birthing in California. Then we have African American populations, we have Asian populations, white, and others mixed and Native and Indigenous, and all the folks that are counted. So people ideally, especially for this very intimate experience of birth, and support all the way up to a year after you've had a baby, want people from their community often to serve them, which means we need to grow a workforce somehow that reflected the needs of the people who would be birthing and looking for services. It would be amazing for us if we were just dealing with DHCS, because after our laborious time and also the time it takes to build relationship, we have figured ourselves out in a way, and it would be lovely if this was all we had to contend with for Medi-Cal. But we don't. Somebody mentioned earlier that the managed care plans is how people access Medi-Cal. So this is just a graphic to show you. The blue part is the part that Medi-Cal, straight Medi-Cal, as we used to call it back in the day, and then everybody else is through a managed care plan. So what that means is for most of the people, there is going to be 26 managed care plans that are covering Medi-Cal in California. That's going to be different in different places. So some counties may only have one health plan that is covering Medi-Cal. Very convenient if you have that. I think San Francisco has I feel like it's a better situation because they've got just one or two maybe. Where in Los Angeles, we have 5, right? And in some areas, so it gets to be that then if doulas are gonna enroll in the Medi-Cal benefit, then they also have to enroll in a managed care plan, and they have to enroll in multiple managed care plans to serve anybody that might come to them in their area. So areas that have more health plans, this has been a very administratively burdensome situation. We'll get to that later, but just wanted you to understand the context. And then doulas in California have been active for over 40 years. So we have a very interesting landscape in California in comparison to other places that are bringing out the Medi-Cal Doula benefits, where their doulas just begun during this wave of the doula of the last 10 years or so when people have started to really talk about it. So raise your hand if you're in the room and you've been a doula for more than 10 years. Right, so we've got folks that are been with us for a while, serving community. Historically, doulas that have been active, the hundreds of doulas working in different places all over California, have been private doulas. They have not been managed by any health system or had to engage with any kind of log taking for a health system. They have not had to bill. They'd send a Cash App, Venmo, hand me a check, right? Basic direct communication with families. They're working with typically self-paying families of means, right? Folks are saying, I want a doula. I'm activated in my health engagement. I am going to invest in you and pay you to serve as a support system for me and my family. And so that's a very, very unique relationship between a doula and their client in comparison to people who might hear about, oh, there's a doula program. Do you want a doula? Sure, I'll take a doula. It's free, right? Okay, yeah, that's fine. Right, that's a very different approach when you get something that is given to you if it's not something that you were looking for or seeking. So there's also a difference in the landscape of the nature of some of the relationships between doulas and the clients, because typically, for instance, a health plan now can call you up and say, we have a doula that is looking for somebody in your area. That's not typically a health plan's calling you. Maybe your fellow doula is calling you, or a past client's friend is calling you, right? So there's more of a relational, historical situation. And then also the demographic of clients that are who typically were working with doulas historically. So you had 2 things. Many of the Black doulas and BIPOC doulas always served our community, usually as volunteer. We did it for free. We did it, for sliding scale. It was relational. If people could not afford to pay. Where now this is an opportunity where everybody would be able to be served very differently than people who were affluent and seeking out services. And then we had these years of pilots, 3 to 5 years of community doula pilots. They were a lot of people brought into this. The PEI, so raise your hand if you're a part of PEI, Perinatal Equity Initiative, anywhere in the counties. Thank you, if any of you are out there who were in those cabs, those early years of the community action team saying, we want doula services in our county. So we've had doula pilots through the PEIs all over various parts of California. Some of the health plans have also had pilots over the years. So HealthNet had a pilot, Blue Shield had a pilot, or a couple. Anthem had pilots, IHP had pilot. Melina jumped on IHP's pilot after they started theirs. So there's been opportunities in California to try out how do doulas work in the health system, and what is the benefit for people who would be eligible for Medi-Cal. So the health plans here have been very aware, the few that participated in pilots, that this would benefit them, This would benefit their bottom line. They've worked out the relationship with a lot of the doula coordinators. And so we're very ripe. That all of this to say, California is unique, because every time some of us have gone to talk about our benefit in other states, and people are like, yeah, we don't have any of that going on. And we recognize that it's been a very unique, very blessed. Many of us feel like it's the ancestors and it's like the time on this planet to have something be created that's sustainable and that can be a light for the future. It's been very unique in California. All right, so the next thing I want you to see is these are some of the logos of the pilots. So if you happen to be a part of any of the pilots that have happened over the past, let's say, 7 years in California, will you raise your hand and just let us acknowledge you? All right, really powerful. Thank you for all of this hard work while we were experimenting with working with systems. It was not easy for any of the pilot managers. Most of us, some of us on here have been coordinators for some of the pilot programs, and we've connected and worked with others. It was very difficult for most of us to build our programs in a systemic format, even more so now looking at building it statewide with Medi-Cal. Okay, so that brings you to like before the Medi-Cal Doula Benefit. So then we get to people starting to talk about doulas in Medi-Cal. We always want to give a shout out to community folks, because a lot of times people who have, like the publications and, a lot of press, people will know that they did things, right? But Black Women, Birth, and Justice in the 2016 Battling Over Birth report, it was called out by community members in the Black community that they wanted to have access to doulas, and they had Medi-Cal, and they couldn't afford to have a doula. And so it was in the report early on from the community that people wanted to have doula access and midwifery access as well. In 2018, National Health Law circulated a survey to doulas all over California to see what doulas wanted to be reimbursed, what was kind of the landscape of the doulas. So I don't know if anybody from National Health Law is here, but shout out to Amy Chen and the crew. You said they were? They have been amazing. Also, I don't think much of what has happened in California could have happened without them behind the scenes and in front of the scenes. And so just, wanted to give recognition to National Health Law for their continuous work.
So Dr. Saida, one important thing that we had talked about in the origin story of the benefit was not only BWBJ's work in battling over birth, but also the impact of COVID. I remember, Kairos, you had wanted to talk about how being a part of pilot programs, trying to collaborate with managed care plans early on, but then the introduction of COVID impacted it was part of the origin story. Did you want to just talk about that real quick?
Believe it or not, California was working on a Medi-Cal Doula Benefit in 2019 and 2020. National Health Law was very much a part of that, and COVID actually pulled it, right? Maybe like 3 weeks before our budget committee hearings. And so there was some concern that if we waited for a federal bill, the limitations would not address the needs of the community. But it has been something that California has been trying to do for a cool minute. It was AB 2258. You can find a breakdown of it online and the elements out of trying to prevent preterm birth.
So then we have a bill that is written, SB 65 in 2001, sort of championed by Black Women for Wellness. Shout out to Black Women for Wellness folks if you're in the house. And other folks that were a part of that, the California Nurse Midwives Association, March of Dimes, Narrow Pro-Choice, California Health Law Program, Western Center on Law and Poverty, and the Women's Foundation California with Dr. Beatrice, Marina Solis Policy Institute. And then 50 other, many of our organizations included, sign on and advocated for this bill to pass. And then it passes, and Governor Newsom, Mashariki was in the House. I remember watching it at home when they were on live sharing about the success of the passing of the bill, which wasn't just about Medi-Cal doulas, it was about many other things, the California Momnibus. But this got it into now shifting over into the responsibility of DHCS to now create, develop, and implement a doula benefit. So I'm going to pass this off to Renee Mullo just to share a little bit about that process on the DHCS.
So thanks for that. So I'm Renee, and I had the distinct pleasure of having the team at the Department of Healthcare Services that worked on the development of the benefit. We knew starting out that, one, with the legislation, it was important to say create a doula benefit under Medi-Cal. We did not want additional strings attached in terms of things that we could or could not do. We also knew that this was a new benefit, so we had to do our work internally in terms of doing research to see what other states were doing. That kind of formed the initial basis for our benefit. But we also had heard from InHelp, the National Health Law Program. They also came and whispered in our ear, like, you guys might also want to consider working with doulas, connecting with doulas. So then we recognized the need for a work group. And so we put out an application request for individuals who wanted to participate in a work group to help assist us in the development of the benefit, because this was something new. We wanted to get it right, and we wanted to have the benefit informed. So if you remember from the earlier panel where the panelists were talking about, making this about us and that advocacy and having that voice. So we knew that it was important for California to have that voice in terms of the development of the benefit. And so here you see the members that were the initial work group members that formed that work group for the development of the actual doula benefit. And it was really important for us to have a cross-sector of individuals. So we did, through that application process, I think we had over 100 individuals submit an application, and then we were deliberate in terms of looking at the individuals, and then also getting input from InHelp, partners within the department with our public health program in terms of thinking through who might be the right people to come and sit with us in the development of this benefit.
Thank you. So then we get into the work groups, and right away, we're like, hey. We should have had 10 conversations before we got into this public work group. So I'm going to pass this, I'll pass it to you, Kefri, and we can just share a bit about those first times in the work group.
Oh, hello, everybody. How you doing? It's all nice to be up here after war, We made it. And the reason why I say that is because we knew that we were standing as front runners and that the doulas that we've been working with for years in these pilots have been deep in the trenches serving birthing people in the hospitals, in the homes, and on their blocks in ways that truly deserve so much admiration and to uplift their work. And so we knew that when we came to the table, and doulas should be at the table, birth workers should be at the table, community members should be at the table whenever defining a benefit that you are going to then use upon their bodies. So the doulas were the voices for the bodies of the birthing people. And those bodies have been at war with these systems of harm for so long that we didn't really have a choice but to go hard in the paint. And we went hard, y'all. I mean, it was really a lot of powerful passion here. And Renee's sitting here because she's a queen, But we came in ready to fight. We weren't coming to lose. We were coming to win. We were, and we would sit back and strategize and think of all the ways that we could come together in community. And many of you here are part of those initial work groups, part of the collaborative documents. This is a real life community benefit that was built with the people here at the table and the people out here. And so I just like to mention that it wasn't all roses. You know what I mean? It was really powerful collaboration, and it was with deep humility that we learned so much from DHCS and your team, and from the powerful advocates and policymakers that we were able to bring in their voices at the table as well.
I would love to share really briefly. The first time there was any kind of community conversation about this, I didn't attend that very first meeting, but my phone buzzed so hard that it slid off my desk. with people saying, Mama Samsara, you have to be on this meeting, you have to be in this meeting. What's going on? And I'd say that it's comical, and I say that because it's real. And what came after that, after many conversations, was this amazing transformation and amazing respect. And partly because we're doulas and we kind of walk like that. And our state, I have so much more respect for, and it's been this wonderful woman I have so much respect for, because it really became clear that they were there to listen, and they were talking to us with corporatese first. And I was like, that's not gonna work. Top-down talking is not gonna work with dudes. Okay, so, oh, hi. Okay, really quickly, thank you, ma'am. See, we don't do that. I'm birthing babies. Anyway, so it was an amazing blending of people. It was people who had that corporate top-down thinking, who were willing to listen and learn. And there were people who did not have that kind of thinking, who were willing to listen and learn. And so we have a benefit. I still got some problems with it, but we're gonna work on that, and we have a really good head start. So doulas, don't back down, don't back away. Come forward, assertive. What we do in the hospitals, right? But whatever doulas, the doula profession is being discussed, doulas have to be present, right? Don't let them talk without you, ever, anywhere, and miracles will.
We talk often about cultural awareness, cultural congruence, cultural humility, and this is one of those spaces where very different cultures clashed, and not necessarily ethnically, right? This was just the state process culture, the doula community culture. Me and my girl Kefri is the hood culture, like all of. And so one of the first learnings when that original call was there, that poor moderator was unaware culturally that she was not going to get Black women to be quiet. And so that was like a lesson learned, right? And so there were a lot of adjustments that came from that. And so the initial team of folks that were the working group, I wanted to be a part of that group so bad, and the closest I could get was the chat box for the panel. And so every time there was something that was mentioned, I was in the chat, like, here's the statistics, here's the, no, that was the second meeting. That was the second meeting. Yes, because they figured out they couldn't get Black women to be quiet. So it was, it is interesting that I just want you to remember that, like, whether or not you're in the forefront and the name on the paper, the need is there to remember the things, because, you know, when we get passionate, sometimes, you know, all of those other foundational pieces are lost, and so you need your getaway driver to to put that stuff and keep folks remembering that, like, you know, bottom line, we are here because moms and babies are dying.
I laugh to see Renee sitting here with us smiling, because there was a time when I don't think that would be happening, you know? And I think it's a commendation to both the state and to us that we came together at a point where we realized that we were all on the same page, we all wanted the same things, and we were coming at them a way different way at the beginning, but we came to a place where we were in unity. And I think that's really important to understand and to realize that that can happen, because, you know, the state of where we are right now, we're looking at, like, I don't know where we are, but when two entities want the same thing so passionately and they want it to work, it can work if we listen to each other. It's the same as listening to women when they talk about their bodies in the hospital. If they don't listen to women, they die. If they listen to them, then things change. And I think it's a commendation to all of us here on the stage that we came to this place. When I tell the story of how we got together, I said, yeah, the state was told that they had to talk to community doulas, and they did it, but they didn't vet us real well, because they didn't realize that they picked the 5 or 6 most opinionated, direct, and take no bullshit doulas in the state to come and sit and talk to them. So it did work out in the end, but I think they were quite surprised at that first and second meeting.
So even though there was, early tension and conflict and, some misunderstandings with how folks operated, we found the need to have, a neutral facilitator for these conversations. So, Saida, why don't you introduce our neutral facilitator?
Yes, so we actually, hold on. So we had a neutral facilitator because we realized we needed one after the first meetings were so difficult. Doulas were calling on it in the chats. Renee tells us later that DHCS was also considering that and the back end as well. CHCF, a really strong partner, Community Health Care Foundation. Also, people were watching, lots of people were watching this conversation on the back end and maybe we can help, right? And so there were a number of collaborations and conversations between DHCS and CHCF about the possibility of them providing funding to DHCS to be able to have and hire a facilitator and a mediator for this process. And so just want to start off saying thank you, and thank you to Amelia for jumping in, Amelia Cobb, who's here with us today, for jumping in and just seeing, this is like the magic of California. We have so many relationships where people in different systems are working together or trying to work together and leaning in, a lot of leaning in. And so, that was just a magical thing. And every other state I go to, I'm like, you champion funders, you want to support these systems getting set up. So then Race for Equity, through a number of opportunities to see who was available. To see who was available was chosen, and I'm going to let Dietrich talk about her organization.
Hello, my name is Dietrich Epps, and I am the president and CEO of Race for Equity, results achieved through community engagement. We partner with public agencies and health systems and community organizations to create measurable and sustainable change. And that's the role we played with the Medi-Cal Benefit for the doula reimbursement. Our work has always been guided by 2 key commitments. First of all, we develop collaborative action to achieve equitable impact, and we transform data into meaningful change for people and communities. So when you think about those 2 things and think about the Medi-Cal Benefit, our work aligned really well with the goals of the Department of Healthcare Services and the doula community and those who support people giving birth in California. So we brought together a team of results-based facilitators, and they guide courageous conversations. And that's what we do. We help support decision making, and we also have a project management team and knowledge management team. And we make sure that we have smooth implementation and that we capture the learning that happens in the sessions. So that's the work that we do. We use frameworks, and those so that you can be clear about how we make those things happen. I wanted to share those frameworks with you. The first one is results-based accountability, which is a disciplined framework that uses data to help support groups move from talk to action. And we also, what we used a lot of with this work of results-based facilitation was understanding the boundaries of authority, role, and task, really helping leaders move with intention, understanding what their role is in the work, and keeping the results in the center of the work, and the communities that are most impacted by that work. So that's a little bit about who we are with Race for Equity.
So we have this establishment that there needs to be a facilitator and a mediator. several of us had already started to sort of rise up in the most active communicators with DHCS on the chats and in the conversations we were having. And then there was let's have a co-design team. Let's actually have, because we showed you that long screen of a bunch of people. All those people couldn't then be in back-end conversations with DHCS, sort of, negotiating all the points, right? It wouldn't make sense. Also, many of them, not all of them, were doulas, and so there were very specific things around the role and the scope of doulas that was being negotiated early on and discussed. And so there was a, sort of an application process or a nomination process for a co-design team. 5 co-design team members were chosen. Those of us that are here, Paisha Edwards at the time was also a part of the original co-design team, originally called the Community Communications Advisory Team. So by now we've already been working with DHCS for about a year, like into doing the co-design team, being behind the scenes before the meetings, seeing documents, looking through definitions, offering up videos. This is what postpartum doulas are. This is like actually doing extreme education, unpaid, all volunteer, in the middle of the pandemic, in the middle of our programs, because we all are pilot program coordinators and leaders. It was a lot. It was like extreme, and we had to have a lot of conversations among ourselves, like, okay, y'all, like, can we keep doing this? How much can we keep doing this? Thankfully, we had really amazing champions in our community. Again, giving shout out to CHCF and the Stupsky Foundation. So in partnership, Amelia Cobb and LaRue really came together and decided, no, we're not gonna let, because now everybody's seeing on the public forums how much work we're doing, and I think, it's lovely. It really felt beautiful to know that people were thinking, are these people being compensated for this? Because, we Black women, we might do a thing for free to help our people. You know what I mean? We might actually lean in and lose sleep and do the most because we know that it will help in the future, but it's hard. It doesn't mean that it's fair and it's equitable. So thankfully we were, yes, please. Wait, let me give you the mic. Hold on, come.
I didn't know it was live streamed, but I really want to give a shout out to Rue as a co-funder. And I think many people do know CHCF, but I have to give a shout out to LaRue because she wasn't in this birth equity work before. And so she's a new funder who had a conversation with me and allowed me to email her and give her all the information I have. And she wanted to join in. And as a funder, it's often about risk. What risk am I taking in this investment? What risk am I not? So she's so humble that I felt like I had to take this moment to interrupt your amazing presentation to acknowledge her and all of the work she did with you all that I couldn't do. So I just wanted to do that. Thank you.
Thank you, LaRue Pendleton.
Yeah, and I just want to say, recognizing, because I'll be the first one to tell you, it was rough when we first started. But when we started having the discussions after like the second meeting, where I had pulled my team together to say like, oh, we need help. And so we had reached out to CHCF. They too were having some internal meetings like, oh, this is rough. We need to kind of step in and see how we can help. So there was a mutual awareness about that help. I do remember at probably the second meeting where I'd asked, like, we cannot do this by a committee of 25 to 30 people. So I'm asking, not telling, but asking, who would be willing to volunteer to work with us? So these ladies stepped up to the table to that challenge. And so there was a question asked of us about payment. Just to be clear, DHCS, we don't pay people to come meet with us. That's not how we work as a state agency. So that was also something new. So in our internal discussions and then talking with CHCF, we also asked, was this a possibility? Because we wanted to recognize what they were bringing to the table. They were helping to fund Dietrich to come to work as that meeting facilitator. And so we let those discussions and that engagement on the funding part, because we had no role in it, that happened between these ladies and CHCF, the Stupinsky Foundation, in terms of that support. But that was critical in terms of the work that we were doing to help make this benefit a reality for the state of California. And that is one of the things I'm really proud of, is what we as Californians and what me and my team did to make our doula benefit a model for other states. And the process that we used to develop this benefit was, other states have some amazing things that they have done, but trust and believe, they do not have the number of enrolled doulas that California has, and we came into this game late. There were other states that had been out there doing this work, like 5-10 years earlier. Some states, Oregon, may have had 20 doulas enrolled. We have over 1,000 doulas enrolled in our program.
Thank you. So we just put this here just to say about the magic of being a co-design team. You want to, Kev?
Just wanted to add, they were probably afraid that we were going to burn the whole damn thing down. But we're forged in the flame, so we live in fire, so it was nothing to us. But at one point, I'm sure it was we didn't know that what we were about to do. That this was about to be so radical, and this was about a reclamation, and this was ancestral. And we came with all that passion. And the people that were in the chats that were happening there, that's how we directly communicated and uplifted the voices of the community. And nobody was going to back down. That was not going to happen on our watch. And so the responsiveness, I think, was an incredible desire to find that equity and to listen to the people, because the DHCS team is here because they want to give the best health care services to Californians. We didn't understand their passion. So we had to lean in to understand the hearts of these individuals that we were basically fighting at one point. We went hard. And they lent in to say, well, we hear you. And it was through that collaboration, this was deep collaboration with the state, when we think about being disruptors, or we think about how we are changing systems, well, here we are, and so you better believe that this is going to be a different place that people are birthing in 10 years. So I hope that we don't lose faith,
And just wanted to say that, if you're out there building anything in a system, which many of us are, think about how to care for each other in the process. Because we didn't survive this just working. We went out to dinner together. We found other people that we could connect with. And so I just wanted to put that in the midst, that this was also a sisterhood that was built that made it so that we could be stronger. And when some of us felt like, I'm gonna have to tap out, these folks are crazy, it was like, that's okay, and then, we could hash it out and everybody could take a deep breath and, do some meditations.
And just to add to that, Saida, one of the things, so we've been preparing for this talk for a long time. And so one of the things that's been exciting is all the different narrative pieces that have emerged, whether from DHCS, Race for Equity, DTREAPS, and then each of the doula stakeholders. And one of the key things in talking about how we were able to implement the benefit so well in comparison to other states that had a head start, some of the different things that came up were the value for transparency, honoring the elders, really dying to ego. I mean, these are the real conversations that were had. So many of us as doulas, and then the communities we come from do doula work differently. The organizations and the pilot programs were different, and yet even with the differences that they had, and we all had as doulas, we realized we honored the experience of each other as leaders, as community members, and we continued to bring the community's voices to the table. And so even within the doula stakeholders of the co-design team, it was really imperative that everybody's voice was heard and that those key values were maintained so that there could be success.
We had an underground.
Yes, the whole
a group.
side. Well, yeah, I mean, that's just literally what I was just I guess, referring to is that, you know, even when we talk about the differences, like Mama Linda and her work with battling over birth and how she's been a doula for a very long time. Is it over 30 years? 35 years, okay? So the doula work, yeah, clap it up for Mama Linda, please. Exactly. So we talk about the work that Mama Linda has done in the Bay Area for over 35 years. We talk about the work Kefri has done in LA, you know, jumping into the Inland Empire, and really all the work we've done across the state. There was so many opportunities for someone to say, well, this is about me or my organization, or, you know, we should have the premier voice in implementing this benefit. But no, in one of the largest states in the country, at every point they were putting ego aside to say, what is it that the community will need in Fresno, the community will need in Barstow, the community will need in Long Beach, the community will need in Oakland, the community will need in San Francisco, the community will need, what's that small, tiny, Eureka, you know? Sorry, Humboldt. So, because that's California, right? And so that's why, as we're taking you through this journey of the maternal health care landscape, of the work that was already happening with doula pilot programs, of the work that all these different members were doing, it also not only took a neutral facilitator, the work of funders, the work of DHCS, the California Hospital Association, the managed care plans, but then also each of these doulas say, no, we're not gonna leave the doula's voice behind. Actually, and actually, Renee said this first, like their voice has to be at the front of this.
I want us to remember that the reason why we're here is because of the women and the birthing people and the babies who are no longer with us. And sometimes that would get us down, y'all. You know, sometimes it was really, really hard. You know, it was because of the spirits of those that are no longer here with us. Really, we had to tap deep into our intentionality, you know, and what we were really creating and stay aligned with that intentionality, because if we didn't really honor the disparities and those who have, you know, come to their demise through the harm of the systems, that's why we were up there fighting. We weren't there just because, you know, this is a cute idea for the doula benefit. We knew that it was truly here to create justice for those who are no longer here. And so I think it just was so profound every time we came to the table that we knew that this is why we were here. And we'll talk a little bit more about that as far as how we wrote some of that into the state plan amendment.
Just wanted to add quickly, but not quickly. We were all being doulas while this was happening. So there were babies being born, there were babies dying, there were miscarriages, there were abortions, there were tears, and then I had to be on Zoom. And that, you know, I think that we all deserve to be seen for that. Life was happening all around us. Sometimes I got to a meeting late, but we showed up because we knew, as my beautiful sister Kefri just said, our ancestors wouldn't let us sleep if we didn't show up, right? And so, you know, grandma tells me to do something, I gotta get going. So it's a hard job, but just like labor is a hard work. At the end of the day, there is so much joy. And right now, we're sitting in the joy of the hard work we've done these past few years.
The other thing that was really, really, really important to me, and to make sure my team understood this. So there was one meeting I wasn't at. It was rough. So I was at every meeting. Towards the end, I didn't necessarily have to, I would be there, but maybe not for the entire meeting because of the working relationship that we had developed over time. What was really important was to listen and to hear. Okay, you can sit there and listen, but to know that you were heard comes back in the words that people see, the words that we reiterate back, but more importantly, in terms of the policies that we had developed. Because when we first started, it was like we were speaking Greek and they were speaking Italian and there was no translator. And we were screaming at one another. And because we weren't hearing each other, we were not listening to each other. But once we got that meeting facilitator And once we all took steps back, and we had to repeat things, bring things back, come back, and making sure that we took the steps necessary to ensure we heard and we understood. Because earlier, like in the first panel, people talked about the words that you use. You got to bring it down a notch. You have to remember your audience and who you're talking to. So we had to learn about doulas and doula work. They had to learn about Medicaid work and what we do as a state government. Because the big block we had to get over were reimbursements. Because we got into, maybe it was the third meeting, and someone said, "Are you really gonna pay us $450? That's not gonna work." And that was like, what? And so we had to reel things back significantly, and we'll be talking about that in a minute, but we had to help educate people. So like Dr. Weber had said earlier about your voice and understanding and being engaged, it's understanding what our processes are. Because there is a process for what we do and how we develop the budget and things of that nature. But we had to take those baby steps to help educate, and then using that co-design team was truly phenomenal and transformative for us in terms of that work, because then we use them to help further inform future agendas and topics that we discuss. I'd look at all the presentations my team would give to me before they were released, and I'm like, didn't we already talk about this? And they're like, but Renee, they want us to bring it back. And it's like, okay. So we would bring it back. We were not trying to drive it by saying, well, this is what DHCS wants you to hear. We wanted to hear from them to make sure that we are being responsive. So it's really important, and it's something for you also to be thinking about as you continue the great work that you're doing and the work that you're doing in your communities, is having that leadership and having someone who's gonna be that champion for you. I was the champion for the work that my team was doing within my leadership, within the administration, in terms of what we needed based upon what we were hearing from the collective group.
One of the things that we realized pretty early on was, while DHCS was learning about doulas and what we do and what that's worth and the time that's put in, we were already impassioned, I would say, because we've been out in those trenches for literal decades. I don't think there's anybody on this team that's been in less than 20 years of doing birth work. And so we had to recognize that and not be mad that they weren't already mad, right? Right. There was that part. But one of the things that was beautiful to see, two things, that as doulas, we doula'd each other. Like, there are hidden documents in the archives where we had conversations to just kind of decompress. And, you know, during COVID on Zoom, we learned to read each other's faces and eyebrows. And, you know, you might message somebody directly on a call like, "Sis, your face, catch your face, catch it." So like, don't blow the people up. But we took care of each other's souls, and we encouraged each other to take care of our bodies. And, you know, there was prayer and there was tears, and so we were real people. There was wine. Wine is good. But the other thing that I don't want to get lost in this is that all of this happened without this idea of creating a thing to comply to. Each one of our organizations did what it does, continue to do it the way that it does, and we didn't, you know, say create this membership hierarchy thing where, you know, you have to look like this and move like this to be a part of this. It wasn't that, and I think that is an even greater skill than all of the other development, that we didn't have to mimic the system that we were trying to fix in order to be in a position to fix it.
I just wanted to share that in addition to all of this behind the scenes, we also were hosting separate, private, as in not a part of DHCS's process, what we called, eventually became called doula access meetings, where, I mean, hundreds of doulas at different points in time have engaged with this doula access, and we met at some points once a month to discuss behind the scenes everything that we needed to think about that was coming up with DHCS to make sure that even though we come from all different regions in California, and even though we are all Black women, we represent a lot of different ethnic groups and backgrounds that we work with and support and even, exist within the ecosystem. We wanted to make sure that we weren't missing anything. So we had these other meetings with all these doulas around California and other stakeholders to say, okay, this is what we're thinking to bring up. This is the issues that came up. This is the last conversation that we had. So every time we had a public meeting with DHCS, we came back and had a private meeting with the community and then went back to DHCS and said, okay, this is what we think and this is what the people are saying. Now what do we do? Well, this is what we should talk about in the public meeting. Then we go back to have a public meeting. So we're always doing like 2 times the work behind the scenes, figuring it out ourselves, going back to the community. And that's the model that we naturally created. Like we were like, we can't just do this and not know what the people say. So now we gotta, so again, National Health Law Program hosted, because who's administratively organizing all these people? Who's sending these emails? Who's hosting the Zoom? Who's remembering to turn it on every Thursday at 4 o'clock or 5 o'clock? Somebody else did it. And I wanna say to these allies out there, we need you. Because, National Health Law, the people who did it, Asian woman, Latina, we're like, we're here holding it. And not that this was just for a Black benefit, but you see the ecosystem of who has been building the pilots, right? We have been doing this behind the scenes. It's going to support everybody. And we all came together. That was a very diverse group of people that were in that behind the scenes, our version of our co-design team. And I just wanted to give shout out to the Doula Access people who don't necessarily get seen, although they were in those chats on the public meetings. But just wanted to note that, and those continue. If you're a doula out there and you're wondering what's going on, we still have those meetings and update people on what's going on in the community. Okay, so then we develop the benefit. We actually write the scope and the definitions. So I just want to read the definition so that folks can just, kind of get a quick recap of what it was decided. You have to actually decide what the doula benefit is, right? Like we kind of assumed, of course you know what a doula is, and of course it's going to be this, right? And so in California, doulas are emotional and physical support people providing pregnancy, labor, birth, and postpartum support up to 12 months, as well as support after a miscarriage and abortion. And so when we had those early conversations, it was very important to the doulas to navigate, negotiate conversations around, to make sure that we could get paid if we supported someone who lost their baby, right? Because in some states, they built the reimbursement off of a live birth, right? Like you're actually building a code for something. What if they have an abortion, right? This person was still pregnant. They still need support, right? People would still need, like we had to have a conversation once, like people needing postpartum support after a loss, but like for how long? Well, I mean, you're still postpartum. Even if the baby's not there, your body is still postpartum, your emotions, and you still will have a lot of needs potentially. And as we know, many people then go on to have another birth, oftentimes within a close proximity. So you're also setting up long-term reproductive health. So, okay. We wanted a couple things that we couldn't negotiate everything that we wanted, but maybe we'll talk about some of the things that were built out around
I'm going to read from this slide too, so you can see that, and also that initial slide that you saw, all those words, those sentences were really carefully crafted. They were crafted with the team at DHCS and her visionary people that are leading. We have to give a shout out to Jim. We call him the godfather of the benefit. We learned so much from Jim Elliott, really deeply, on how to collaborate and how to craft something, because he then had to put it into the state plan. So we were a part of actually writing the state plan amendment. All of these words were infused with our passion, were infused with absolute solutions in mind, and knowing that we are carrying this torch, right, of this fantastic work that is eons old. And so these are some of the things that we achieved here. You must be at least 18 years old to become a Medi-Cal doula. We actually we fought for the young doulas, but there was this is the compromise. There's adult infant CPR certification. You have to complete a basic HIPAA training, obtain an MPI number, get your business license if that's required. And then we came up with 2 qualification pathways, the training pathway or the experience pathway. Now, all of this was written within Google Docs, by the way. And I'm going to talk about the 2 and 3 a.m. session that Dr. Said and I were at, like falling asleep on our computers. Like, we got to get this ready for the doula access meeting. We got to figure out how we're going to define this and how we're going to workshop this. And it was really important because that experience pathway was really what was called the grandmother pathway. It's very important for us to not forget this. Why? Because before this was a California Medi-Cal Doula Benefit, this is a cultural inheritance. You know, this is as old as the great Mother Earth. And this is from the hands of the grandmother midwives and the grandmother baby workers and the grandmother birth workers and the great ones that come before us and upon whose shoulders that we stand, that we are here. And we wanted to deeply acknowledge those ancestral ties and know that those who were working with lived experience in the community deserve to become a Medi-Cal approved doula to serve their community. And we wanted to write that into the benefit. So it eventually became the legacy pathway, I believe is another word, and then they were like, we're okay with calling it the experience pathway. We were like, okay, we'll compromise.
But we still call it the legacy
pathway. We still call it the
pathway.
grandmother pathway, and it's important because this is an African indigenous tradition. This comes from the historical strength and courage of those great ones before us, and we would not be here without them. We only have about 20 minutes left, Doc.
All right. We want to make sure that everybody could have a doula no matter where they birthed. In some states, if you have a home birth, you can't have a doula through the Medicaid system. And that wasn't going to work for us because doulas support everywhere, right? And so that was something that DHC has reassured us, that doulas could work everywhere. And I think that that's important for folks to know that that's unique for California. We had to go back and forth a lot about the actual scope and how often doulas see people and what it looks like. And so in some places, people have built out a global benefit, right? So if you're a doula, you get $1,500 for whatever you do. But the whatever you do in these streets, since we had been doing it in these pilots, right? Like I think when people built them in other states, they hadn't done pilots in the same communities that they're about to do this in Medicaid. People are calling you. They're asking you for support, for navigation of basic stuff that the health plan half the time is supposed to navigate, right? But your doula ends up doing it for you. So you're gonna see your client typically 3 times, before, 3 times after, but you're also gonna be on the phone with them for hours and on Zooms for hours, multiple times in between. So in our conversations with them, they realize that, oh, okay, maybe the $450 that we were planning isn't gonna work because you're talking about hundreds and hundreds of hours with a person, not even including a birth that could be 7 hours or could be 35 hours, right? And so there was a lot of negotiation, and long and short of it, we got to a place where everybody felt like we were understood for what it was going to need, and they also helped us understand how it would need to be structured with like a fee for service that could reflect that. And ultimately, we were, it was settled on these rates. And I don't know what happened fully behind the scenes, but thank you, Renee, and all the people.
So again, we did our work internally. We looked at Oregon, and at the time, Oregon's rate was $350. So there were discussions, and we landed on $450. Okay, that was in our Medi-Cal estimate. That was approved in the governor's budget. But when we had the discussions, people were like, are you freaking kidding me? No, that does not cover our work. So then we took that information back internally, and we had internal discussions. And so where we landed was looking at what we reimburse our licensed providers, because through the extensive conversations that we were having with everyone, we were looking at, either we develop a rate, that takes too long, for what we were trying to accomplish, because our benefit was delayed. The implementation was delayed because we were supposed to go live in 2022. We went live in 2023. Because of the voices and hearing, we were not ready. And there was still work that we had to do in terms of the policy development and the work on the rates. So where we landed with the rates was looking at what we pay our licensed providers. And hindsight is 2020, and I'll tell you why. So we looked at, we weren't gonna develop a rate because that just took too long. We tried to look at what other states were paying. on an individual basis, like a per visit basis. Then we landed on tying it to what we pay our licensed providers here in the state. So whether you are a physician, a nurse practitioner, or a licensed midwife, everyone is paid the same amount. So our doulas are paid the same amount. So as there are rate increases in those areas, the rate increases will also accrue to the doulas. So hindsight is 2020, and that became a nice thing for us to say that what we did in terms of the rate development. So that's why you see the rates that we have today. And so if all the visits are accomplished, including some of the additional postpartum visits, then it could go up to as much as, it'll be over $4,000 if you're able to do that. And I think right now, California is still we pay our doulas the highest rate in the nation. Other states, I think, are trying to come up to us. I don't believe anyone has, achieved that yet. But then again, we're California. So they can follow us in terms of what they do. But that was how we had developed the rates for the doulas. And so that's what will continue. And what we did in terms of justifying the rates, because some of the licensed practitioners, no disrespect to any that are here in the room, but we looked at it to acknowledge the time. Because that was the thing that we heard, is all the time that is spent with our birthing individuals. And so it's not just a 15-minute increment, because the doctor, nurse practitioner, they see them in the office, do their assessment. You all know that have had babies. You go in, you see your licensed care providers. You may be there 10, 15 minutes, and then you're on your way. But that's not what happens with doulas. So we wanted it to be also reflective of the time that is spent in terms of supporting our birthing population.
Yeah. I do remember when they announced the original rate, and we were like per hour, per day, like what is it? But one of the things that we were tasked with doing was not just protecting our clients. We've heard for the last 2 days that tragedies occur after the postpartum period, and we tend to say postpartum because in the birth world we mean like until the baby goes to college, but but medically, after day 43, you are SOL. You're no longer considered postpartum, and so we knew that our families would need care. That a crisis wasn't going to wait till the 6-week visit, and that things occur after that time period. But we also had to take care of ourselves and our souls, right? Because you have to pay parking coming out of those hospitals, and you have the gas, and then there's the child care and all of that. So in that rate, we were thinking about, and the amount of times that we get to support our clients without having to fight for it, and the fact that we also have to take care of our own families was a huge consideration.
So, okay, we have a lot to get through in 8 minutes, Saida, because we want to make sure we leave enough time for Q&A. Yes. And then the lunch people are going to come, okay? So we have to,
Okay.
look, the lunch people. All right, so this is the big slide. So a couple of things about how we were able, so you guys, just to recap, now you've gotten into a little bit about how we built the benefit, building the benefit with the doulas in mind, building the benefit with the birthing people in mind. Everybody's on task to do that. What did it look like to implement it? What were some of the key strategies we used to overcome barriers? And then we'll just touch on briefly the successes that we've had, okay? Ready? All right, go.
Successes. No clinical supervision requirements. No referral needed. No limits on providers who can recommend, right? So in some places, a doctor or a nurse has to recommend, and we know until there's a great relationship with doctors and nurses and doulas, some doctors and nurses are gonna say, I don't want my client to have a doula, so no, you can't have a doula. We said, let's let it be any healing art person, anybody who has a license. A therapist can offer it. A fellow, a chiropractor, even a dentist can make a referral. Standard postpartum visit referral form. So that there was this extended postpartum visits that were allowed. We asked for formalized forms to make it easier so that people didn't have to get a doctor to write something up. It's like, can you just give us a thing and they can sign it and put their, make it simple for the system. No certification requirements. This is big. In many states, doulas have to be certified in some organization, typically, historically, also very white-led, dominant culture organizations that have, it's a very expensive pathway to certification. It's a barrier. And we have places in California, I think everywhere deserves to have doulas that have been practicing. Mama Linda, for instance, who's been practicing for 35 years, wouldn't be able to enroll in our benefit if it was built like some of these other states built it. We didn't want to make barriers for this. So we had really strong training standards, and experience standards without certification. We have the 2 pathways, which we talked about, a training pathway, an experience pathway. No limitation on training organizations. A lot of other states have a list of training organizations that you have to have trained from in order to be a doula. Guess who that limits? Anybody who doesn't know those training organizations. We got, Kimberly Durden, who was a midwife in our community, who's been doing doula trainings for years and years and years and years. Many of us have trained with Kimberly Durden. If she didn't do the paperwork that it would take to get her training organization certified in some system, which system? A state system? A government system? We don't have time for that. We need people, we need doulas to be ready to go as soon as this starts, and we'll talk about the barriers. There's already enough barriers. Obviously, increased reimbursement rates, we already talked about that, and telehealth, big deal. We all learned after the pandemic, we are gonna do a lot of visits, not even just because it's convenient to the doula. Many of our clients are like, I don't have time. Can you just hop on a Zoom with me? I can ask you my questions, you can teach me. And people are doing whole schools online, right? There are people getting whole degrees, doctorates online. You can't tell me somebody can't do a quality service online. And of course, doulas are in person with their clients for many of the visits. So we didn't want there to be a difference in rate because that is how a lot of people are still really leaning, especially the younger population, really a lot of times want to have more telehealth than they do live sessions until they need it.
On that telehealth modality, just to make sure it's clear, it's the same rate. We do not do any reductions in those rates. So where doulas provide services, if you're doing a doula service, you're gonna get paid for doing a doula service, regardless of the setting that you are in.
Thank you, thank you. There was a lot of advocacy. There were a lot of articles. People were very interested in this process. When we were having challenges, they were calling us up on the phone, tell us what's going on, what's happening with the state. We were on the call, and so I think, it can be helpful to have a public experience of a process that's going to affect the public, because then it also puts the right amount of pressure for what really people value in the community about what's happening. And maybe many things worked. So we're very thankful for the folks in media.
Also, wanted to talk a little bit about.
Do you have that advocacy slide, Saida? Do you have the advocacy slide, or are we going to share from Deidre?
And so want to share what Deidre shared about what it took to turn the corner for Race for Equity, the facilitator, as they were working with us. Is that okay? Okay.
Also, wanted to talk a little bit about some of the challenging parts of doing this work in facilitating the doula stakeholder group meetings and the doula implementation meetings. One of the greatest challenges that we found was being able to build trust across these very different worlds. There were state policymakers, state departments, and managed care plans, community doulas, really helping these worlds to come together so that there was a brave, safe space created for the conversations to happen that could move the results forward. So the doulas brought a lived experience and a long history of advocating for birthing people of color, especially. But many, up to the point where Race for Equity joined, had felt excluded or unheard in their previous conversation efforts. On the state side, I would say there were complex billing rules, compliance requirements, and cost models that they were looking at. So bringing these two realities together while designing a benefit that's equitable and reimbursable and sustainable, it required a lot of patience. And so this environment needed to be developed so that the groups could hear each other, and also to have cultural humility on all sides, to recognize that not one group or one person had all the answers, but that there was a need for everyone to kind of listen, lean in, and this required very deep facilitation skills. And not only facilitation skills of the doula groups and the partners, but it was also a public forum where others could join and join virtually across the state. So it was our role to facilitate all voices being heard and heard in the moment sometimes. And so these were challenging conversations to facilitate and design. And we found ways of doing that that enabled the questions to be answered in the virtual chat quickly, and also for the voices that were experiencing challenges to be dealt with, if not immediately, after the meetings occurred. So it was a challenge in facilitation, results-based facilitation, but also a challenge in making sure that there was a trusting environment that was eventually created over time.
All right, so we're going to skip us ahead to implementation. So, what's it going for? There we go. So the implementation section of the work group, another work group was established to do the implementation. So we built the benefit. This is what a doula is. This is how many places you're going to be able to bill, et cetera, et cetera. Now it's open the benefit or get it to a place where we're looking at how it's going to actually be implemented. So how the managed care plans are going to be involved in all of that. A whole new stakeholder work group. Not everybody was switched out, but there were some new players that came on. So we had a large stakeholder work group again. We added Kairos and Chantel to the co-design team and continued in our process to work toward understanding and agreement about new things. Some of the barriers that came up during this stage, DACS was very necessary to make improvements around the managed care plan stuff, and still is. Like, we are still in conversations because now it's in the hands of the managed care plans. Like, we built this beautiful thing that would be perfect if everybody would just do what was built. But people add things. Lawyers feel like they need extra parameters for the doulas to be a part of certain managed care plans. There's a whole lot of barriers that 26 different managed care plans get to come up with their version of how to onboard a doula. We thought it would just be what we came up with, which was already as arduous as it needed to be. So that part is something that we still seek DHCS's support with. A lack of a coordination and transparency between each of the groups, like the managed care plans, DHCS, California Hospital Association, the doulas. Like, we don't actually all have a regular relationship, but we're all about to with this benefit. So a lot of behind the scenes things, and I don't know if you are responsible for getting us those meetings with California Hospital Association. Yeah, of course. So people realize we need to bring some new players in. They need to hear what the doulas are saying, a similar process, and actually really a lot of success in at least getting some common understanding. Then there was a lot of advocacy, so I'll let Kefri take over on advocacy for a bit, just to share briefly.
Yeah, thank you. When you see all the things that are up there, right, all the end of the recommendations and all the ways that you become PAVE approved and what was required of the managed care plans in order to onboard and contract doulas, all of that was worked out in extreme conversations and at the table when we were in these doula access meetings, when we were at the DHCS public meetings. And a lot of it took us understanding and diving deep into all plan letters, what was the current legislature, and how do we work around and understand the legalities and the protections of this new provider class. And so a lot of advocacy action had to happen. So we had community advocacy in action, meaning when we knew something had to change, we had to base it upon whatever was the new regulation or the law and ask for these things specifically within the law. So a lot of times we were just holding DHCS accountable to what they said in the all plan letter. How can we have corrective action for these managed care plans if they're not going to do what they say they're going to do? This is where these community sign-on letters started happening. And with the help of national health law and all of the signatures, maybe many of you might have signed some of these letters, and then DHCS received them. They listened to them. They worked it out and came back with a plan. And so it was this kind of like infinity loop. We found the concern. We grounded it in our historical awareness and understanding what was needed. We brought it to the community, and they brought it back. And in doing so, there was a lot of press coverage that came about, and press coverage was very important to create the leverage. And then there was also some politicians that took some interest, right, and said, hey, my constituents want fair treatment and equitable treatment at birth. And so all of these things contributed to this change. It wasn't just us at the table saying we'd like this, it looks cute. You know, this was about really amplifying the voice of the community and using the legislature, all plan letters, and the different methodologies that we were able to lean into.
So this is just some visuals, and we put the QR codes there. You all have access to the slides, but if you want to see the actual letters that were written, like what it looks like to write a letter for advocacy, we've made them available for folks. Best practices for the hospitals, community doulas and advocates worked on that, and then the hospitals themselves came together, a couple, and some managed care plans to come up with theirs. So a lot of really collaborative work. You want to talk about the feedback form real quick?
Absolutely. So we couldn't just come and say this was happening in this hospital, the doulas are not getting let in here, or they're being asked to leave in the postpartum world, or, you know, these things now became allegations. And we didn't really want to drive this through allegations. We wanted it to be driven through data. And so we collected qualitative data from the doulas with the California Medi-Cal Doula Benefit feedback form. And so anybody here is having problems with implementing yourself as a doula, a new doula, or this benefit in your hospital or your birth center or in your community, we ask that you make these complaints on the California Medi-Cal Doula Benefit feedback form. It's this data that DHCS welcomes and receives, right? The California Hospital Association welcomed it. They actually created some new papers and even a press statement regarding letting doulas into the hospitals, letting them do their jobs, that we can help these mothers, these birthing people, and these babies, right? And so a lot of this was done from the voices of the community and by journalists taking note and also collecting the data so that we could no longer just be, I mean, I don't want to lessen the role of doulas, but sometimes, you know, we have to come with hardcore stuff. And so I know everybody here knows that, but the fact that DHCS received it, and with receiving it, they actually created the solutions with us. And it was really profound to witness that.
And then this is where we are today. So as far as enrollment, we had started off even in June of 2023 with 123 doulas enrolled in PAVE, and now we have over 1,000. And so that's a feat. There are very few states that have 1,000. I don't know if any state has 1,000 doulas enrolled yet. So we said, well, we have 160,000 people who birth in Medi-Cal. We have a ways to go. Doulas only do but so much every month when it comes to helping people who are pregnant and postpartum. So we know that there is a desire to grow that, but it's moving. It's moving, as you see, in a very forward trajectory. Yes?
One of the things that is invisible about that number is how many of those enrolled doulas individually and as organizations walked through that process, sat them down one by one, sat them down in groups, online trainings, in-person trainings, meeting with people multiple times, because these are systems that as community providers we had not touched, like the billing and any of those things, but even just getting started, we had to doula the doulas.
Heidi, you have a visual, and while you show that visual, I just want to just capitalize on what you shared real quick, Kairos. So, like, what it looked like is what Samsara talked about earlier. You know, Kairos is doing a training to train doulas, but then she might go to a birth, but then she's actually going to help a doula sit down and figure out her way to get through PAVE, and then try to help that doula figure out how they're going to get their business license, and then jumping on a Zoom meeting and meeting with DHCS and meeting with the co-design team and getting in the Google Doc. Like, all of that was happening and is still happening at the same time. So when you look at this image of the where doulas are enrolled across the state, what Saida has done is she's transposed the logos of the different organizations just so you can have an image of where you see the work. Okay, like, it's not an accident that, you know, Los Angeles County has 241 doulas enrolled in the benefit, okay? We're busy. Same thing with Alameda. Mama Linda's goal is to train 100 doulas in the Bay Area. She just trained 97 doulas in the past year, and 66 doulas are enrolled in the benefit. That's huge. In the next slide, real quick, you'll see we're still putting in work in the Inland Empire. We're putting in work in Orange County. Listen, and we're not stopping, right? So that's the whole thing. You build the benefit. There's the origin story of the benefit. Then you're implementing the benefit, and it doesn't stop.
I just want to shout out, I'm looking for right there. There's a young woman there named Tiffany Murphy who probably got 60 of these people signed up by herself. It's not just us sitting here on the stage that's doing this work. The doulas are taking it on themselves to bring their sisters with them. I have a doula who works with me, Misty, who's been on this since January of 23. She signed up, so she was a guinea pig for all of this, and now she is going to be one of our billers, and she's going to help other doulas bill. It's a doula dueling doulas thing. You know, we have to help each other to get this done. It's not just the people sitting up here.
And this is also why Chantel is here, because early on, Chantel was like, I will be the first runner and take it on. And how many managed care plans do you have contracts with? Yep, several.
Several.
And yeah.
I was just going to say, I mean, all the doula sisters in the room, folks here who represent the PEI, people like Defina who opened doors for doula trainings to happen with Grounded Beginnings, Deidre Consumpos, Bianca Reed. I mean, it really is a community effort. Lee Walker is not in here right now. She's with the Abundant Birth Project. Her and I have sat many hours since December of 2022 saying, hey, this thing is coming. Let's see what the website looks like in January. And it was rough. So we could talk about this all day.
30 seconds is that everybody here who's passionate about this work, we still need your help. We need your help deeply. There are still a lot of barriers with contracting with managed care plans, let alone getting these services right into the communities that need them most. Most community doula programs are not funded anymore. They're funding the Medi-Cal programs, and so we're in this deep need for infrastructure and capacity support. So I just want you to know, if you feel it and you want to join and you're here, your voice is what has helped us create this change, and we still need your support.
I want to lift up that my practice is having monthly doula meetups, and we crunch together and we talk about this program and we help each other. So if you would like to be included in that, please chat with me. Mama Linda's doing amazing stuff. It has to be a doula attitude and approach to get the success that our beautiful clients deserve.
Yeah. So I'll skip to those slides where you can see the offerings that exist in the community that have been created for folks to help enroll. So there's a Medi-Cal Birth Worker Resource Hub. It's a website that has the process for this in a more lay terms, kind of vetted by community doulas. DACS has a lovely website that explains how to get through PAVE. But of course, DACS stops at their part, right? But the other part is a managed care part and all these other things. They don't know all the programs that folks have created to help. You know, so it's got a place where you can look based on your region, what organizations like some of ours have, like, you can go to them. We've given scholarships to hundreds of doulas at this point to get their business licenses with funding by the Stufsky Foundation and other folks who've made it possible to help us help the doulas that are coming on. Talked about the LA County Doula Hub, and you can get a QR code if you want to know about support to Los Angeles doulas trying to enroll. Samsara, who mentioned, Kairos also has a program. So all these QR codes, you have access to this. Mama Linda has a group. They're active, regular places that you can go to get support. And lastly, you have an offering, the Doula Lab. Okay, there are offerings. We have lots of offerings. If you need it, they are there. In closing, it's been our honor to lay the foundation for a future where every birthing family in California has access to a doula. Thank you.
One question.
Hi, my name is Zoya. I'm with Raya Health, and I just want to say it's been such an honor sitting in your presence. You actually inspired me to to come back into healthcare. I used to be an investor in Silicon Valley, and when I saw the work being done, I was actually part of one of the pilot programs out of HealthNet for being a doula. I'm trying to serve both my communities. I'm actually half East African, half South Asian, so sitting in both worlds, it's black and brown bodies, like we have to do the work. One thing that I come from a provider family, and when I've been talking to them about the doula program, they're like, the biggest thing is all these new words like EOBs, prior auths, revenue cycle management, and that, I really do not want this benefit to fail. I want to push, I want to make sure that every single person has what they need. How do we, interact with, for example, I just got off the phone with Cal Optima, and they're denying one of our claims for one of our patients. How do we keep pushing? I would love to fight insurance. I love fighting insurance. How do we keep pushing the needle on this? You know me, I'll fight anybody. I'll fight Anthem, I'll fight anybody. But how do we keep pushing? How do we keep doing this work? You guys have created a future for birth work now. You're inspiring us to come back and do the work. What can we do from a technology point of view, from an advocacy point of view, from the EOBs, prior auths, all of that stuff? How do we do the work? And thank you so much.
Okay, so real quick, there's so much to implementation, right? And the question you asked is multifaceted. So from a tech issue, there is administrative support that doulas need, obviously, right? From failed reimbursements or rejected reimbursements, advocacy is needed by members to complain to their managed care plans that they are not able to get provider services because managed care plans are making it difficult. So that is where the accountability still needs to lie. Using the Medi-Cal feedback form that we've created is critical. Everyone who's a provider and or a member needs to submit feedback to that form, because that's what we have to show the managed care plans and DHCS, hey, we built this, we're trying to implement it, and these are the barriers that we're facing. So administrative support, tech support for doulas, ensuring that members' voices are heard, so that gap between the doula and the member isn't, so that it's filled, and there's that barrier from all of these forms that we are all facing. So I am contracted with like 7 managed care plans just because of this, right? And so it is a serious issue, and this is why feedback is critical. Kefri?
Also, I would say, and I'm going to lean into Mama Kim's download that she gave at her speech earlier, continue to dream, continue to envision, continue to set your intentions. Do not stop. Be unrelentless and be fearless in what you want to accomplish. And I'm meaning that for everybody here, because if we stop dreaming and we pretend or we go into fear, which we know is wrong for the birthing body, let alone for our own bodies, then we will not co-create this together. So we really need you to continue being innovative and finding innovative solutions, and to dream big and to lean in and to start those communications. I really encourage everybody here to ensure that they have a problem, to make sure you make a provider payment complaint. You must file provider payment complaints. You must find out your legal rights and get legal support. You should not be signing big contracts without legal support. So we have some of those resources for you. So you're gonna find right now, we're about to get legal support in here, and a movement attorney is needed, because a lot of these things are affecting us, are discriminatory, and we also need the funding and the infrastructure. So my ask of you is to lean into your innovation, into your dreams, and if you think that you need to do it, get up in the morning, step, get to doing.
Real super quick, your next, Kairos. Remember our ancestors. We all got them. And us black folks have some mighty ancestors in this country who are helping others to birth babies under the most ridiculous and heinous of circumstances. As tough as it is now, it's not as tough as it was then. Okay, so, and babies got born, and they built this country along with other beautiful folks and their lineages. So don't forget them. And folks who are prayerful, pray. And folks who do yoga, And whatever you do, do it, because that's the first thing that gets put to the side when things get hard. I don't have time to exercise. I don't have time to pray. You do need to make that time for your own body's replenishment and for the work that you do.
And while a lot of these processes are being developed, and these are things that take time, right? We know that our lives don't pause while we wait for solutions. So I would encourage you to get to know people, because relationships is how we got this done, right? So if you have an issue with a particular entity, find somebody there, make a connection, make a relationship, like make yourself matter to that person so that they can walk you through things that you don't know on the public facing side, or know who the next person is to talk to, or just care that you're struggling, right? So don't forget the piece about relationships in any space where you are offering resources, right? You don't just say, hey, here's the number to a shelter. You find somebody at that shelter and say, hey, my client needs housing, right? It's the same process with any of these things. Find your person and work both ends.
The other thing I wanted to say is just in terms of some of the concerns you're raising, use the resources that we have put into the PowerPoint presentation, because these services they don't require prior authorization. So if people are being denied payment, there's a problem there. So use the resources, contact DHCS. I just want to say, so I'm retired. Woohoo for me. I'm retired. But I just want to say in front of all of you, this has been one of the most challenging and rewarding things that I have done for the Department of Healthcare Services for the state of California. I am honored and humbled to be here today with you all, because it meant a lot to me in terms of making this benefit work and making it something that you all could be proud of. And I remember those meetings and how hard they were. And so I was there for the face of the department and for my team to support the challenges, because we wanted to make it work, but we had to do a lot of, not backtracking or anything like that, but we had to kind of reevaluate how we engage with stakeholders. And it's really something I am very proud of that we did, and that can serve as a model for other states. And even within your communities, thinking about challenges that you all may be having in terms of advancing and getting people to understand what this benefit is about. So there's a lot of lessons learned and a lot of things that we did, but I am just so proud of the work that we have done, proud of the enrollment numbers, but more importantly, proud to have been with these ladies in terms of the development of this benefit. So I just want to say thank you guys.
And thank you all. Thank you.